Welcome to my complete psychiatry review for steps 2 and 3. If you don't know me, I'm AJ. I'm the producer of AJ Monics, a channel where I used to produce fun medical animated videos for retention, but viewers seem to like my questions. And actually, my Step 2 review series now has over 1 million views. Seems to be becoming one of the top Step 2 resources out there. In this particular video, we're going to have 150 psychiatry questions covering everything you need to know for steps 2 and 3, and it's going to be a fast, focused, fun review. And as I always like to say, you guys are amazing, you got this. Let's begin. Question 1. A diagnosis of schizophrenia requires A. hallucinations, B. delusions, or C. at least 6 months of symptoms. And the answer, believe it or not, is C. at least 6 months of symptoms. That is, in schizophrenia, we usually see hallucinations, especially auditory, but they're not required for diagnosis. For example, a patient may have negative symptoms. So hallucinations and delusions are not required, but 6 months of symptoms is required. Remember, if it's less than that, it's either brief psychotic disorder, if it's less than a month, or between 1 and 6 months, schizophreniform disorder. Only when it's more than 6 months do we call it schizophrenia. And just to review the 5 A's of negative symptoms. The affect is flat, avolition, that is they have no motivation, asociality, a word that is basically never used in the English language, anhedonia, and apathy. And this is really important for the exam. Negative symptoms actually respond poorly to medications. They used to make this distinction between first generation and second generation, but the truth is, negative symptoms are basically impossible to treat with medication. Close to impossible. The real treatment is psychosocial. For example, social skills training. But no risperidone and no Haldol is going to take a patient who sits in his room with a cigarette all day, out and about, functioning like any other. The best you can do with that is social skills training. Question 2. What do sertraline, escitalopram, linezolid, monoamine, oxidase inhibitors, and triptans have in common? Besides the fact that they all have I in their name, serotonin syndrome. Yes, all these can cause serotonin syndrome. And that's why we wait 2 weeks, for example, after starting an MAOI to start SSRIs. Alright, and I mentioned 2 weeks, but the truth is, for something like fluoxetine, we actually wait 5 weeks, because for fluoxetine, the washout is much longer. Alright, here I just have a chart for causes of serotonin syndrome which can show up on the exam. Take a look at the antidepressants. Basically, all antidepressants cause serotonin syndrome, at least the typical ones. Other exam favorites are linezolid and triptans. And of course, St. John's wort. That medication seems to find its way into every exam. Now, presentation of serotonin syndrome, you could take a look over here. I've highlighted hyperreflexia and myoclonus, because while the other ones, for example, may be seen in neuroleptic malignant syndrome, what makes serotonin syndrome unique is the hyperreflexia and the myoclonus. Actually, over here, I compare serotonin syndrome and NMS. That in serotonin syndrome, we see the myoclonus and hyperreflexia, whereas in NMS, we see the opposite, rigidity, lead pipe rigidity. In terms of treatment, serotonin syndrome with ciproheptadine, I always think of a sipping hippie dean, and in NMS, dantrolene, or you may see bromo. Alright, question 3. Schizoaffective disorder. Schizo for psychosis and affective for the mood component, which can be either depression or mania. Now, this is a pretty awful question I have over here, but the point I want to get at is to qualify for schizoaffective, we have to see psychosis for at least 2 weeks without a mood episode. That is, the psychosis has to be independent of the mood. If the psychosis is always dependent on the mood, then we just call it a mood disorder with psychosis. For example, a patient that's depressed, and when they're depressed, they get psychotic. That's why for schizoaffective specifically, we need to see psychosis independent of mood for at least 2 weeks. Alright, concept 4. For schizophrenia, there's a better prognosis if, which of the following? The onset is acute rather than this delayed onset. The age of onset is when the patient is older. That is, we see the first signs of schizophrenia when the patient is, for example, 40 years old. And when we see positive symptoms, it's easier to treat positive symptoms than negative symptoms. And of course, good medicine adherence leads to better prognosis in schizophrenia. And here are just some schizophrenia flashcards that I put together. Let's go over some important points. First episode schizophrenia, we generally treat with second-generation antipsychotics. For example, risperidone. Treatment-resistant schizophrenia, we use clozapine. We often use clozapine, especially for exams. Clozapine is great for treatment-resistant schizophrenia. Schizophrenia with suicidality, clozapine reduces suicide risk. And schizophrenia with non-adherence, for example, the patient just doesn't take their medication, go with the long-acting injectable. Alright, question 5. EPS symptoms are seen with typical or atypical antipsychotics. They are typically seen with typical antipsychotics. Of course, we may see them with atypicals, but we generally see them more with typical antipsychotics, such as Haldol, and the typicals are known as the first-generation antipsychotics. Now, just to remind ourselves in terms of the mechanism, typicals have stronger D2 blockade, which drives the EPS. Atypicals have additional 5-HT2A antagonism and weaker D2 blockade, which helps mitigate the EPS. Alright, you can take a look at this chart over here where I compare first and second generation antipsychotics. And I compare that in first generations we see EPS, and in second generations generations, the atypicals, we see metabolic syndrome, such as weight gain, especially with olanzapine. All right, question 6. What is the term for the following? I feel like I am watching myself go about my day. This is depersonalization. I am not deperson in my body. I feel like I'm outside myself, as opposed to derealization, where the person feels like they're not real, like they're in a movie or in a dream. I'm not real. Derealization. These are both subsumed under depersonalization derealization disorder, DDD. They have one or the other of these, recurrently or persistently. Question 7. A diagnosis of generalized anxiety disorder requires, just like schizophrenia, at least 6 months of symptoms. And in this case, 6 months of worry on most days. It's true that in generalized anxiety disorder we may see sleep disturbances, but it's not required for diagnosis. It's often seen, but not required. To get a diagnosis of generalized anxiety disorder, anxiety is not caused by drugs or another psychiatric disorder such as fear of panic attacks, that would be panic disorder, and the anxiety causes significant clinical impairment. They're not just worried about their exam tomorrow, it impairs them significantly throughout their day because they're worried about so many things. Question 8. Which other condition requires 6 months of symptoms for diagnosis? We talked about schizophrenia, and we've talked about generalized anxiety disorder. Another one is ADHD, my favorite, because I have it, and oppositional defiant disorder. Requires 6 months of symptoms. Panic disorder, that's symptoms of worry for at least a month, and acute stress disorder actually has to be less than a month to be considered for this diagnosis. It has to be impairment for less than a month post-trauma, and actually has to be between 3 days and 1 month. More than a month, it's PTSD. Question 9. What's the treatment for ODD? Medications or therapy? And unfortunately, there's no medication for ODD. Therapy. Parenthetically, in my opinion, it's usually the parents that are off, but that's just silly me. ODD requires therapy. Work something out so that the child feels validated and understood. This is in contrast to ADHD, which of course is treated with primarily stimulants, and intermittent explosive disorder, which can be treated, for example, with mood stabilizers. Question 10. GAD first-line treatment, of course, is SSRIs. Antidepressants are used to treat generalized anxiety disorder. We always have buspirone, Buspar, that's used to treat anxiety, but honestly works more as a placebo. The real treatment for GAD is SSRIs, of course, in addition to therapy. For example, CBT. Buspirone is not first line, beta blockers are more for performance anxiety, and benzodiazepines are for the short term, not first line. And of course, avoid the benzodiazepines in patients above the age of 65 or 70. They could sometimes do the opposite of what you really want in the elderly population. Alright, which of the following is first line for OCD? Just like in generalized anxiety disorder, SSRIs. We learned about clomipramine amongst the TCAs that are used to treat OCD, but clomipramine is second line, not first line. SSRIs are first line for OCD, and antipsychotics may be used in treatment-resistant OCD. Now, in addition to SSRIs for OCD, the primary form of therapy is ERT, exposure and response therapy. All right, question 12. I'm terrified of being alone in public places. This is agoraphobia, fear of crowds. I only feel safe being at home, often associated with panic disorders. As opposed to social anxiety disorder, that's more about feeling self-conscious in social situations, and it impairs the patient. Social anxiety disorder is treated with CBT and SSRIs. If it's the performance type, for example, public speaking, as I said, beta blockers, propranolol. Question 13. What is the treatment for PTSD nightmares? These guys don't seem like they'd be in a nightmare, more like in a funny dream. What would be the treatment for this? Prazosin or prazosin, an alpha-1 blocker, is used to treat PTSD nightmares. Just look out for blood pressure, because if it's too low, we avoid prazosin. For PTSD, CBT, and we consider SSRIs or SNRIs. If it's less than a month, remember it's called acute stress disorder as long as it's been 3 days post the event. And again, we treat that with psychotherapy and CBT. Question 14. A patient has suicidal thoughts 2 months after his wife passes away. He states that life is no longer worth living anymore. He can't get anything done anyway, and he hates himself. This is not normal. This is major depression. The guilt involved, the impairment involved, and the fact that he hates himself all point to major depression, not normal bereavement. In normal bereavement, even if the patient may consider, I don't want to be alive, passively, intermittently, but the self-esteem is preserved. They don't hate themselves. And the sadness tends to be specific to the deceased, and the patient generally remains functional. Question 15. A fixed false belief is a delusion. Let's define these terms over here. An illusion is when there's a misperception of something real, as opposed to a hallucination, which is perception of something not real. I hear or see something that's not real, that's not there, as opposed to a delusion, which is a fixed false belief. Question 16. Antipsychotics eradicate a patient's delusions. This is false. Antipsychotics are generally not so effective in eradicating a delusion. The patient may be less persistent or fixated on the delusion, but it's not eradicated, generally. We try our best to reduce the persistence or the fixation on the delusion. Delusional disorder, here are the subtypes: paranoid, somatic, erotomaniac, grandiose, and jealous. And for this diagnosis, it has to be present for at least a month. And I just put this term over here, folie à deux, a shared delusion between two people. For example, a parent and a child where they share a delusion together. Question 17. A depressed patient has hallucinations which occur only when the patient is depressed. Again, this is what I said before, major depressive disorder with psychotic features. This is what separates it from schizoaffective, in which case I said that psychosis must be present for at least 2 weeks, independent of the mood, to qualify for schizoaffective. Question 18. A 20-year-old woman with bipolar disorder is stable on lithium. Which labs require regular monitoring? We need to check thyroid and renal. And that's because lithium can cause thyroid and kidney toxicity, hypothyroidism, and renal failure. LFTs need to be checked, for example, in a patient on valproic acid, Depakote, and glucose, for example, in a patient on olanzapine. As we said, second-generation antipsychotics, especially olanzapine, can cause metabolic syndrome. We need to check the glucose. Question 19. A 32-year-old man has bipolar with a history of multiple suicide attempts. Which medication is most effective in reducing suicide risk? Lithium. As much as we hate lithium because it causes nephrotoxicity and other problems, it is the most effective mood stabilizer or psych drug in general to reduce suicidality. And that's why some psychiatrists just love lithium despite the adverse effects. It uniquely lowers suicide and mortality in bipolar disorder. Other mood stabilizers lack this effect. Now just a few suicide points. Let's say a patient has a lot of emotional turmoil. They've been using drugs and they're in a crisis. So they're at an elevated suicide risk. You have to ask them before leaving the hospital about hopelessness, about suicidal thoughts. Also, how do you ask the questions in a direct, specific way? Were you trying to kill yourself? You have to ask about ideation, plan, and intent. For a drunk patient, reassess suicidality after sobriety. Wait until they're sober. Don't ask them about their suicidality when their blood alcohol level is at 300. And this point shows up all the time. Previous suicide attempt is the single strongest predictor of a future suicide. Question 20. A 20-year-old woman with anorexia nervosa refuses to eat. Her BMI is dangerously low, her heart rate is low, and her blood pressure is low. So she looks unstable, and therefore the next step is inpatient hospitalization. With anorexia, if she has unstable vitals, we need a medical admission. And here apparently I have another question 20. To prevent refeeding syndrome, monitor electrolytes, especially phosphate and potassium. And parenthetically, oral phosphate is generally safer and more steady. IV only if severe or the patient cannot take PO. Question 21. A woman is very provocatively dressed. She breaks down in tears when no one notices her. This is histrionic personality disorder, in the same cluster as borderline and narcissistic. And here we see the 3 clusters. Cluster A, the odd and eccentric. The cluster B, the dramatic and erratic, and the cluster C, the anxious and the fearful. Question 22. A 22-year-old man is started on haloperidol. Within hours, he develops painful neck spasms and his eyes roll back upward uncontrollably. This is acute dystonia, and it's treated with benztropine, cogentin, or Benadryl, anticholinergics, which restore the dopamine-acetylcholine balance. 23. Here I have a 23-year-old woman. This age I purposely put here. She has a severe urge to move constantly. This is best managed with propranolol, because this is akathisia. Akathisia is treated with propranolol. Now, benzos can help in akathisia, but they're second line. Normally, we give propranolol for akathisia. Akathisia, I can't fit Isha. Apparently, his girlfriend's name is Isha, and he's trying to tell her, I can't fit still. All right, another EPS. Tardive dyskinesia as a side effect of antipsychotics occur after months or years. This actually helps us differentiate the different types of EPS. And in general, this is the timeline. Acute dystonia occurs generally, this is a generalization, between 4 hours and 4 days after taking the antipsychotic. Parkinsonism between 4 days and 4 months. Tardive after 4 months and up to 4 years. And akathisia, as well as NMS, which we spoke about before, can occur anytime. Now, tardive dyskinesia, tardy means late, and that's why it makes sense it occurs after 4 months to 4 years. And here I just have a chart comparing the different types of EPS, their presentation, and what their treatment is. Question 25, where do we see convulsions, coma, and cardiac arrhythmias? Side effects of which antidepressant? TCAs, or TCCCAs to help you remember that. Neurologic, cardiac, as well as anticholinergic symptoms. That's why we see orthostatic hypotension, dry mouth, and urine retention. Question 26, an appropriate initial medication for a patient with major depression, insomnia, and weight loss, so we want them to gain weight, we would give them mirtazapine. Mirtazapine helps with appetite as well as sleep. Amitriptyline, well, TCAs in general are not first line. Question 27, which antidepressant is contraindicated in eating disorders? And the answer is, Wellbutrin, bupropion. And that's because it lowers the seizure threshold. And this applies both in anorexia and bulimia, where there's already a lowered seizure threshold because of the imbalance in the electrolytes. Question 29, adjustment disorder develops within 3 months after the stressor, and it doesn't last more than 6 months. The patient may have anxiety, depression, and this is following a stressful event. What's the treatment Treatment for adjustment disorder, psychotherapy. We try to avoid medication. 31. A patient has chronic depressed mood that is present on most days for at least 2 years. So it doesn't fulfill the criteria for MDD. This is persistent depressive disorder, dysthymia, and it's treated similarly to major depressive disorder. Question 32. Can mania involve psychotic features? And the answer, of course, is yes. That's often seen in bipolar 1, where we see mania with psychotic features. And once it reaches psychotic features, we have to treat the psychosis with an antipsychotic. Question 33. Which mood stabilizer causes this? This is Stevens-Johnson syndrome, and it's caused by lamotrigine. For exams, the answer is going to be lamotrigine. That's most associated with Stevens-Johnson syndrome, but also carbamazepine, not lithium or Depakote. And here's just a mnemonic for Stevens-Johnson syndrome causes. You can take a look at this. Question 34. A mood stabilizer, first line for trigeminal neuralgia, is carbamazepine. One that has a narrow therapeutic window. It causes Epstein anomaly, and it's contraindicated in poor renal function, of course, is lithium. And as I said before, it reduces suicide risk the most of all mood stabilizers. 36. A monoamine oxidase inhibitor that's added to aged cheese can lead to hypertensive crisis. There's an abrupt, drastic increase in blood pressure, for example, above 180 over 120. That's hypertensive crisis. Now, it wouldn't be aged cheese alone, it would be any high tyramine foods, such as red wine. This is one of the reasons why we avoid monoamine oxidase inhibitors, and it's pretty rare to see a patient come in with depression being treated with a monoamine oxidase inhibitor. Question 37. Postpartum psychosis requires hospitalization. The answer is true. Now, what does psychosis look like? It's 2 to 3 weeks of episodes of psychosis, such as delusions, and there's a major concern for the baby. We must hospitalize. Question 38. A patient has MDD and SSRI has failed. What is the next step? The answer is another SSRI. We try another one. ECT is when there's treatment-resistant depression, and phototherapy is when there's seasonal depression. Now, an example of switching from one SSRI to another would be a patient's on fluoxetine. They start developing insomnia because it's quite activating. We switch to escitalopram. Lexapro, which has a calmer, safer SSRI profile and doesn't activate as much. Question 39. First-line treatment for severe mania is, well, here we're having severe mania, perhaps with psychotic features, so again, we give valproic acid or lithium plus the antipsychotic for the psychosis. Depakote, by the way, is the term for valproic acid, and risperidone will be an example of an antipsychotic. Question 40. A boy had conduct disorder diagnosed in 7th grade. Now he's at age 21. He lacks remorse and breaks the law, and now he's an adult. Antisocial personality disorder. Conduct disorder as a child is a requirement for this diagnosis. And just a mnemonic, conduct disorder in children, antisocial in adults. Question 41. I want to go to the party, but I'm scared no one is going to like me. I'm staying home. This is avoidant personality disorder. Cluster C, the avoidant ones. This separates it from schizotypal, where the patient wants to be alone. They like being loners. They like being left alone. In avoidant personality disorder, they wish they could form relationships. They just have too much anxiety surrounding that. Question 42. Here's a defense mechanism. What's it called? A guy has a crush on a girl, and then he goes and insults and embarrasses her. The opposite. Quite a counterproductive thing to do. This is reaction formation. The person behaves opposite their feelings. Here's another one. The nurse is totally awesome. Oh wait, she insulted me. She is totally bad. Of course, this is splitting, seen in borderline personality disorder. Another defense mechanism. I just got fired from my job. I want to kill my boss, but instead, I will treat my wife like a queen. This is amazing. This is sublimation, where you channel unaccepted wishes into acceptable behaviors. Question 45. A child has ADHD. The mom doesn't want him to take a stimulant, so what's the next step? We don't call Child Protective Services. We offer atomoxetine or guanfacine, which have been less associated with addictive behavior. Atomoxetine, by the way, which is officially an SNRI, and guanfacine is an alpha agonist. But look out for the side effect of exhaustion in that child. Guanfacine is known to cause fatigue. Question 46. The child gets extremely angry a lot, and this happens for over a year. This is disruptive mood dysregulation disorder, which is diagnosed only after the child is above the age of 6. Below that, it's just called a tantrum. Question 47. Diagnosis for Tourette syndrome. They have motor tics and vocal tics, for example, grunting, for more than 1 year. And the treatment for Tourette's, which is probably more of a neurology topic, is tetrabenazine, a VMAT2 inhibitor, and the alpha agonists clonidine and guanfacine are not as good for tic reduction, but it would be good in a patient, for example, with ADHD. Coprophilia, probably not going to show up in an exam, but just for fun, is sexual arousal from feces, but this will be more likely to show up in the exam. Coprolalia, which is speak inappropriate, obscene words. Echolalia is when the patient repeats the words that they hear, often seen in autism. So what's the best initial treatment for alcohol use disorder? Naltrexone, an opioid receptor blocker. Naltrexone is first line. It reduces cravings and it can be used while drinking, but we avoid this in opioid users or significant liver disease. You could look at disulfiram every year, which we don't use as much because we don't give this while the patient is actively drinking. So it's much safer to go with naltrexone. Question 51. Antidepressants are used in addition to psychotherapy for, in general, bulimia. Meaning, in anorexia, we generally don't use antidepressants because it's not effective until we restore the patient's weight and their health. Just in terms of the distinction between bulimia and anorexia, bulimia is when the patients are not underweight. Anorexia, they are underweight. In terms of the definition of bulimia, it's not only when the patient vomits, it's also when they purge by exercising. Question 52. I want to see what's going on over there. This is one of the fetishes. This is voyeurism, looking where one shouldn't look. as opposed to exhibitionism, which is showing for arousal when exposes themselves, and frauderism, I don't really know how to pronounce that, that's rubbing, for example, against someone in a subway. Question 53, I hate my gender, that's gender dysphoria. We treat with education and address the concerns, otherwise there's an increased risk of suicide. Question 54, a patient feigns symptoms because he likes the warmth and comfort of the psych unit. This is malingering. They're doing it for a reason, for secondary benefit. This is as opposed to somatic symptom where there's distress because of a symptom, or conversion disorder where there's a deficit unexplained by medicine, often due to a traumatic experience. Factitious disorder where the patient self-injures, for example, to assume a sick role, or does it through proxy or on another, and malingering, which was going on over here. Question 55. A patient gets depressed in the winter, that's seasonal affective disorder. Antidepressants take how long to work? 5 to 6 weeks. Patient has an eating disorder. What else is possibly seen? Kleptomania. Yes, kleptomania is associated with eating disorders. Question 58. Opioids and other sedatives can lead to decreased pH, i.e. acid, and there's going to be retained CO2, respiratory acidosis, and as opioids decrease the respiratory drive. Question 59. Fluoxetine hasn't worked for 3 weeks. What do? She still feels sad and low energy. Maintain the current dose of fluoxetine. And as we said before, there's a 5-week washout. Question 60. Basically, first line for ADHD is going to be methylphenidate, as well as amphetamines, plus or minus therapy. Question 61. This is the red rash which we described Stevens-Johnson syndrome associated most with lamotrigine. Discontinue the mood stabilizer right away. Question 62. A 21-year-old female presents with chief complaints of feeling tired throughout the day. She also feels pain in her legs at night. This could be associated with restless leg syndrome, associated with iron deficiency, and that could explain why she's so tired. Question 63. An 18-year-old girl is brought in by her father. She vomits at each meal. She also has a normal BMI. Again, this is bulimia, where they have a normal BMI and they purge. And we treat with SSRIs. 64. Here we have a man who comes in distressed. He has to click the light switch 30 times or else something bad will happen. This is obsessive compulsive disorder. In obsessive-compulsive personality disorder, we see more of a need to control their surroundings. And it also, by the way, parenthetically, is ego dystonic. They don't want their condition, as opposed to it is ego syntonic. Their behavior is consistent with their own beliefs and attitudes, as opposed to OCD, where they really get so much anxiety from their symptoms and they want to get rid of it. Question 65. An 18-year-old presents with vomiting, diarrhea, and diffuse aching muscles. This is opioid withdrawal, heroin withdrawal. You'd also see fentanyl withdrawal. Vomiting, diarrhea, and diffuse achy muscles. Question 66. A 53-year-old female on haloperidol presents with lead pipe rigidity. Remember before, neuroleptic malignant syndrome. As opposed to in serotonin syndrome, we see hyperreflexia. Question 68. A 29-year-old female presents with elevated prolactin. This is seen in first-generation antipsychotics, specifically haloperidol. It's also seen in risperidol, but between the first and second-generation antipsychotics, we see it in the first generations. Aripiprazole, by the way, actually reduces the amount of prolactinemia, which is quite interesting. Question 69. A 32-year-old is admitted to the hospital. She says to the residents that the nurses, quote, are so bad, but that you're the best doctor. This is splitting, seen in borderline personality disorder. Question 70. A 12-year-old boy presents with facial stiffness and a mild hand tremor. This could be associated with not really a psychiatric condition, but Wilson disease, which affects the copper levels in the body, and patients often present with psychotic symptoms, as well as Parkinsonism features seen in this patient over here. Actually, I wrote over here that Wilson disease often presents first with psychiatric symptoms, such as mood changes, irritability, and personality changes, before the classical neurologic or hepatic signs appear. Question 71. We have a patient with dilated pupils, hyperthermia, and decreased bowel sounds. We need to get an EKG. This could likely be a TCA toxicity. That's why we see the anticholinergic effects, the dilated pupils, the hyperthermia, also anticholinergic, and decreased bowel sounds. We check the EKG because TCA can cause cardiotoxicity. Question 72. What is the sleep pattern seen in a manic episode? So we see a decreased need for sleep. It doesn't increase REM. We talk about REM sleep specifically in relation to depression, where we see an increased REM density and a shortened REM latency. Question 73. Which dopamine pathway, if decreased, can lead to gynecomastia in a male? Tuberoinfundibular. Wish I had a good mnemonic for all four of these, but the tuberoinfundibular is associated with gynecomastia. Question 74. A patient on clozapine should be monitored for neutropenia. They've changed the regulations on it, but it still requires ANC monitoring for neutropenia. Question 75. Here we're seeing a patient that has tics, and they're mistaking it at school for misbehavior, but he really just has tics. Of course, as we said before, tetrabenazine. 76. Nightmares, a person in combat. This is post-traumatic stress disorder. Remember, when it's less than 1 month, it's called acute stress. Question 77. Best treatment for PTSD, as we said before, SSRI or SNRI, in addition to CBT or exposure therapy. 78. Anxiousness for 7 months. Generalized anxiety disorder. Remember we said it has to be more than 6 months. Question 79. Treatment for generalized anxiety disorder, an SSRI or an SNRI. Here, paroxetine. Paxil. Question 80. Treatment for restless leg syndrome. We said before to look for iron. A potential treatment could be dopamine agonist such as ropinirole or pramipexole, but here the option is gabapentin, which can also be used to treat restless leg syndrome, gabapentin, or pregabalin. 81. Something that can cause a monoamine oxidase hyperadrenergic crisis, fava beans, due to the increase in catecholamine release. So look out for those fava beans. Question 82. Here, there's no reason to assume that there's an illness. The patient doesn't have symptoms, but they're worried about being ill. That's illness anxiety disorder, which used to be called hypochondriasis. Question 83. An adolescent with irritability and withdrawal, and they have somatic complaints rather than overt sadness. So here we have to screen for depression because sometimes in teen behavior, it comes out in interesting ways, such as social withdrawal. Question 84. How do you treat tardive dyskinesia? With something like valbenazine, another VMAT2 inhibitor. And question 5, we see this guy who is balding over here. This is a psychiatric condition, actually, trichotillomania. They have anxiety or OCD or something like that, leading to hair loss. They pull out their hairs. And we can take a look at the bald spot. We see hairs of various lengths. We contrast this with alopecia areata, where we see a very, very defined bald spot, which is completely bald, and telogium effluvium, which is a fake diagnosis, which just means they're thinning. Question 86, trazodone most commonly causes not priapism, but somnolence. Priapism is very rare, even with trazodone, but every patient gets tired with trazodone. That's why we give trazodone not primarily for depression, but to help patients sleep better. Question 87, after Alzheimer's disease, the most common cause of dementia is vascular dementia, which causes 20% of the cases of dementia. Other causes I've included over here, such as degenerative, such as Huntington and Parkinson. Question 88. Patient 71-year-old has a 1-week history of muscle twitches associated with startled response. So here I'm describing Creutzfeldt-Jakob disease, which is associated with 14-3-3 protein, and a more specific new test is the real-time quacking test, which I wrote over here, which might show up on the exam. But again, it's more of a neurology topic. Question 89. A patient has a mini-mental of 14. Remember, normal is above 24, and the best you can get is 30. So if they have 14, do they have dementia? Not necessarily. Remember, they could have other things too, such as delirium. In fact, the definitive diagnosis for dementia really requires autopsy and pathology, which is rarely done, but we have other tests, such as PET scans. Here I compare delirium and dementia. Dementia is not waxing and waning. It's more chronic and it's more constant. One of the treatments that we give, especially in Alzheimer's, is the cholinesterase inhibitors. Question 90. The first line for borderline personality disorder is therapy. Dialectical behavioral therapy. Question 91. A patient has on prednisone, they develop mania and insomnia. We have to reduce the steroid which may be causing these symptoms. That's the trigger. Question 92. A patient says, I can turn a red light green by clapping my hands. This is seen as schizotypal, where they have magical thinking, I can do magical things. As opposed to schizoid, where they are loners. Schizoids decide to be alone. They want to be alone. Question 93. In primary care, the first step after identifying cocaine use is brief counseling intervention. Don't give them immediate referral. Talk to the patient yourself to build trust and motivation before the referral. Question 94. A patient with severe IV cocaine use, unstable housing, and no support should be referred to inpatient rehabilitation. This is something that we do in detox. We do the 6 ASAM dimensions to determine that the patient needs inpatient rehabilitation. Because if we send them to outpatient therapy, they're most likely going to go right back to their drug or their other addiction. Question 95. In the ED, an agitated patient is triggered by their spouse. The first step is escort the spouse out. Before we restrain the patient, we remove the trigger. And here it's the family member. Question 96. A patient with MDD reports vague suicidal thoughts, but no plan or intent. The next step is actually outpatient treatment. Not every patient who has passive suicidal thoughts needs inpatient hospitalization. It could be that if you assess that they're not a threat to themselves currently, then it's okay for outpatient treatment even if they have passive suicidal thoughts. As I wrote over here, low-risk patients can be safely managed outpatient with support and monitoring. Question 97. An adolescent drinks alcohol but doesn't see it as a problem. The best approach is motivational interviewing. Don't just confront them about the dangers. They're not going to listen to you. They don't want to hear it. They want motivational interviewing. For example, how it may affect their basketball season because it interferes with their game, and their true ultimate goal is to do well in the basketball season. So here they see that you have the same goals as them and they want to listen. And it avoids resistance. Question 98. A child on methylphenidate has appetite suppression. The best step in management is encourage a big breakfast before dosing. We have to give them a big breakfast, then take the medicine, which will reduce their appetite. There are medications available, for example, such as cyproheptadine, which can be used in patients who lose their appetite due to stimulants. Question 99. A patient is non-adherent to medication. The best first step is ask open-ended questions to explore reasons. Open discussion uncovers barriers and builds collaboration for adherence. Question 100. A patient in the ED becomes violent, hitting staff and breaking objects. The next step is, at this point, we need restraints and antipsychotic because violence requires immediate safety measures. Question 101. A patient is chronically suspicious and hostile but has no fixed delusions or hallucinations. The most likely diagnosis is paranoid personality disorder, which is very rare, by the way. It's usually associated with schizophrenia. Paranoid personality disorders, as well as all the cluster A's, are very rare. But since there are no delusions and hallucinations, on this exam question, we would say paranoid personality disorder. Question 102. A pregnant woman presents with acute mania. The safest and most effective initial treatment is haloperidol. Haloperidol is effective for acute mania and safe in pregnancy, unlike valproic acid, which causes lots of problems. Question 103. A suicidal patient refuses hospitalization. The patient's best response is use empathetic communication about safety. By the way, these questions from 100 and on are more associated with step 3 than step 2 in general. For the step 2 component, you could stop here if you like, but it could show up, so it may be worth it. All right, let's keep going. Question 104. Before discharging a suicidal patient whose family keeps firearms at home, the most important step is to arrange safe removal of the guns. Limiting firearm access is a key suicide prevention measure. Question 105. A child with Tourette syndrome should be closely monitored for which comorbidity? As we said before, obsessive compulsive disorder is the most common comorbidity in Tourette's and often emerges later in childhood. Question 106. A patient newly diagnosed with HIV is afraid to tell their partner. The best first step is encourage the patient to tell their partner. Question 107. If they refuse, then you should notify the Department of Public Health. Question 108. The best management for a patient with somatic symptom disorder is schedule regular follow-up visits with the same physician. If you don't do this, then they're going to make appointments all the time and they'll meet you in the parking lot. Structure consistent visits, validate the concerns, and reduce unnecessary tests. Question 109. An older adult with sudden memory loss, poor concentration, and loss of interest is most likely experiencing depression with pseudo-dementia. That's why they have the loss of interest, and it was sudden. It wasn't gradual like with dementia. Depression can mimic dementia, but cognitive symptoms improve with treatment as opposed to dementia. Question 110. An older adult with a first depressive episode after age 65 is at increased risk for future dementia. Late onset depression is a marker for late Alzheimer's disease or vascular dementia. Now from here on, by the way, I just have one slide with the answer. I'm sorry about that. It's just I wanted to save space. We're already on slide 393. Question 111. A college student requests high-dose immediate release stimulants for ADHD. So here, the first thing we're going to have to do is verify the ADHD diagnosis with collateral information. You don't just trust the college student that he needs these high-dose release stimulants. Question 112. Confirming the diagnosis and functioning helps rule out stimulant misuse or diversion. Question 112. A 22-year-old man with daily cannabis use presents with new onset paranoia and social withdrawal. Which is the best clinical approach? So before we diagnose a condition, we of course have to defer any diagnosis giving until after we get abstinence. Cannabis or other drugs can cause substance-induced psychosis, so we can't diagnose them yet. Question 113. A patient with bipolar 1 disorder stops medication and reports mania. The best next step is not to confront them and insist the patient starts medicine, but ask about early warning signs of mood symptoms. Because exploring insight builds awareness and opens the door to relapse prevention education. Question 114. Which of the following prevents dementia in healthy adults? Not vitamins and supplements that have not shown to be effective, but rather lifestyle measures like exercise and cognitive stimulation. They can slow down the progression of dementia, or apparently in some cases prevent it altogether. Question 116. A patient has partial response to an SSRI with persistently low energy. The best next step is augment with bupropion, Wellbutrin. And that's because when patients show a partial response to an SSRI, the preferred strategy is augmentation rather than switching medications. Question 117. A woman 6 weeks after delivery has guilt, low energy, and impaired concentration. The most likely diagnosis is postpartum depression. Remember the guilt and remember the 6 weeks. Postpartum blues, however, are mild and self-limited within 2 weeks. 118. A breastfeeding mother with postpartum depression does not improve with therapy. The best step is sertraline or paroxetine. These are preferred, as opposed to fluoxetine, which accumulates in breast milk and is less safe. Question 119. An overweight adolescent is diagnosed with early onset schizophrenia. The best initial treatment is aripiprazole. Abilify is preferred due to low metabolic risk, as opposed to olanzapine, which is associated with increased weight, and this patient over here is already overweight. Question 120. An adolescent asks you not to tell her parents she's skipping insulin and misusing stimulants. Let's say she's 16 years old. The physician, therefore, in this case, should inform the parents due to safety risk, because safety overrides confidentiality when behaviors are life-threatening. In some situations, such as with birth control and relationships, even at the age of 16, we don't tell the parents, and this is because the risk of telling parents, i.e. that the won't open up in the future, outweigh the benefit. All right, we're up to the last 30 questions. Question 121. A college student presents with anxiety, tachycardia, dilated pupils, and agitation after using stimulants. We use benzos for stimulant toxicity. Question 122 is telling us SSRIs and SNRIs, as well as CBT, are first line for panic attacks. Benzodiazepines are only for acute relief. SSRIs and SNRIs and CBT, as well, are first line for panic disorder. The benzos are only for acute relief. Question 123. A woman has recurrent unwanted thoughts of stabbing her children, which causes significant distress, but no intent to act. She has OCD. It doesn't only affect one's actions, it could affect their thoughts, which is actually very difficult to diagnose as well as to treat. Question 124. An adolescent presents with cutting behavior but denies suicide, ideation, plan, or intent. The best next step is a comprehensive psychiatric evaluation. We don't have to hospitalize immediately because maybe the patient is not even suicidal. Maybe they're doing it for attention. Maybe they're doing it to displace their emotional pain through self-harm. Question 126. I guess I skipped to 125. A patient presents with insomnia, poor concentration, and loss of interest in activities. The most appropriate management is to start an SSRI. We don't treat the insomnia until we treat the depression, because once the depression resolves, their insomnia will likely improve on its own. alone. Question 127, a returning veteran has irritability, poor sleep, and emotional detachment. We want to screen for PTSD, as we mentioned before. Question 128, an older woman is distressed by intimacy but hesitates to discuss it. Ask about it outright. Ask open-ended questions about her sex life. How is your sex life? She may be a little bit uncomfortable at first, but she'll feel validated in the normalcy of it. Normalizing sexual health and using open-ended questions encourages honest discussion. And question 129, in primary care, all adults should be screened for unhealthy alcohol use. Question 130, the most effective pharmacotherapy for smoking cessation is varenicline and nicotine replacement therapy. Question 131, a patient makes frequent non-urgent calls and seeks reassurance all the time from the doctor. What you need to do is set clear boundaries, but remain empathetic. So look for the answer that balances empathy as well as clear boundaries. Question 132, again, St. John's wort. You should tell the patient about significant drug reactions. Now, actually, St. John's wort has shown benefit, but it's not really regulated, and therefore, don't tell them that no evidence of benefit. Tell them that there are significant drug interactions. For example, it induces CYP450. It could also cause serotonin syndrome. Question 133, a psychiatrist considers dating a former patient. This is always unethical. Romantic relationships in other fields may be permitted in certain circumstances, but not in psychiatry because of the enduring power dynamics and risk of harm. 134, to reduce risk of smoking, parents have to quit too. Don't expect from the kids what the parents aren't doing. Question 135, in cardiovascular disease, depression should be treated because depression worsens outcomes and SSRIs are safe. Question 136, a patient starting fluoxetine develops mild insomnia and restlessness after a few days. As I said, fluoxetine can be an activator, so what you want to do is continue the SSRI and reassess after several weeks. She's only been on it for a few days. The side effects may dissipate. Question 137, after remission from a first episode of major depression, antidepressant should be continued for 6 months. Just because you haven't been depressed in 3 months doesn't mean you should stop taking your antidepressant. But you don't have to wait 3 years. 6 months is considered standard. Question 138, a patient with postmenstrual dysphoric disorder is not improved on fluoxetine, so switch to another SSRI. Don't start the GnRH agonist. First try another SSRI. But if all else fails, a GnRH agonist can actually help. Question 139, a patient on SSRI develops persistent sexual dysfunction, so switch to a non-SSRI. Or an SNRI, switch to bupropion, which has less sexual side effects. If it's the inability to retain an erection, you can go with sildenafil, Viagra. Question 140, a patient has only modest improvement on the max tolerated dose of an ADHD stimulant. You're not going to get any more benefit out of it. Switch to another ADHD medication. Question 141, a 4-year-old is diagnosed with ADHD. The best first-line treatment is not medication for a 4-year-old, but parent-child behavioral therapy. We don't start giving the stimulants at age 4. Question 142, a patient with Parkinson's disease has fatigue, poor concentration, and low mood. The best explanation is depression come over with Parkinson's. It's not a motor symptom of Parkinson's. Patients with Parkinson's tend to get depressed. Question 143, what are the most common causes of psychosis in Parkinson's disease? Dopaminergic medications. Not the Parkinson itself, but the dopaminergic medications can induce psychosis. For example, amantadine. Question 143, a patient asks for euthanasia. The best response is not to explain the laws on the physician-assisted suicide. That is not validating at all, but rather to explore the patient's concern with open-ended questions. Question 144, a 13-year-old with moderate major depression has not improved with therapy. The next step is to start fluoxetine. Fluoxetine has shown as to be first line for pediatric depression. Actually, fluoxetine is the only SSRI FDA approved for children above the age of 8. Lexapro if they're above the age of 12. Question 145, the reason why patients ask for euthanasia is actually not because of uncontrolled pain, but because of loss of autonomy and dignity. They feel like they can't do anything anymore. They're always in their wheelchair. They can't leave their house. That's why they want to no longer live, which is very sad. Question 146, children raised by same-sex parents are at increased risk of, well, no increased risk compared to heterosexual parents for any psychotic or psychological conditions. Parenting quality matters more than orientation. Question 147, a woman presents with acne, hirsutism, irritability, and high hematocrit. The most likely cause is anabolic steroid use. That's why she's getting this hair, virilization, mood changes, and high hematocrit, erythrocytosis. Question 148, a college student requests high-dose immediate-release stimulants. I already did this question before, sorry about that. We want to verify the ADHD diagnosis. 149, the best proven strategy to prevent dementia in healthy adults is lifestyle measures. Oh man, I did this one too, I'm sorry about that. Okay, so we have a repeat on this one, you better get it right on the exam. And 150, a bipolar 1 patient off meds reports impulsive hypomanic behavior. The best response is ask her about early warning signs, not confronting her, insisting her on restarting meds. So I guess these last 3 were repeats, but that's okay. We got a lot of review. I really hope you benefited from this review. I know I got a little fast at the ends. That's what I generally tend to do. That's why I try to save the most important information for the beginning. All right, stay tuned with me as I continue this step 3 review. Please post your comments here if you have any questions, if you have any comments. I tend to get more emails and comments about how I make people happy more than that I give them information. But I've gotten so many comments about how I've helped people on step 2. I would love to hear your comments. I'd love to hear your feedback. I'm open to positive feedback. I'm open to negative feedback. Alrighty. Good luck in your exam. Take care.